Good morning, everybody. So we carry on with our talks and presentations. I think today we are going to be discussing what we left last time, which was on ergonomics. Based on the program, we have anatomy remaining, we have electrosurgery that we'll be talking about, and then we'll go to hysteroscopy as well and discuss this in detail. So I think that should cover up pretty much the basics that we need. And then I'll end it up with how to improve laparoscopy skills quickly. So this is how we will move. So ergonomics, we had discussed about this last time. And we will continue, but just as a brief, it's important that ergonomics is to help us suit to our type of work properly so that we have least injuries involved in it. It covers a number of things which we'll be discussing as listed below. It is to provide ourselves with the concept of ergonomics, to understand what are the problems at laparoscopy, know how to assess any damage that might be happening, and how to manage this problem. What is ergonomics? Well, it is derived from the words ergon and nomos, which is the natural laws or arrangement for work. So it is the science of best suiting the worker to his or her job. And it focuses on three things based on what task you're given, the tools you have to complete that task, and the type of workplace that you have to try and merge the three. So this is what we said. I mean, moving a dustbin from A to B could be by lifting it, or could be by pushing it, or rolling it. And obviously, anybody can tell that this is going to be an easier way of pushing it. So this is very important. It helps us from being injured. It optimizes our productivity, and it increases the comfort of working. We had stated here that, I mean, if you just look at this picture, the most ergonomic person is actually the anesthetist here, who is relaxed in a comfortable zone, and he's not twisting his neck. He's having an angled down view. So this is what we mean by who is the most ergonomic. Going back to history, it was in the 18th century that doctors did require that workers who required to maintain body positions for long periods actually developed musculoskeletal problems. But it's over the last 20 years that research has clearly established a connection between, for example, certain jobs and certain injuries. And Park and team in 2010 actually presented and published an article about physical strain at laparoscopy being more than 87% of the times. So to differentiate open and laparoscopic surgery, we said that in laparoscopic surgery, ergonomic ceiling is actually quite low, which means that it's very easy to get tired, it's very easy to get injured in laparoscopic surgery as opposed to open surgery. A few principles that we started discussing. Number one, straight line principle, which means try and have yourself with your hands, the pathology, and the screen in one line. So if you're operating in that position, you're way better than if you have to operate on a side. Try and maintain the visual axis and the motor axis as the same. So how I work and how I see should be in same line. Motor axis, visual axis. This is motor axis, this is visual axis, that's opposite. So that's going to be a problem to you over long periods. You cannot operate in that fashion. So it's like coaxial alignment and lateral alignment, what I just showed you. One of the other principles or of ergonomics that we need to remember is the table height. So remember, the surgeons, the assistants are all of different heights. So when we are of different heights, if this is the table height, for me, this is probably ideal. If I was that short, this is not ideal. If I am taller, that is again not ideal. So what I'm trying to tell you is when you're operating, you need to try and see how to maintain an ideal height. So how do we do that? The ideal height is roughly around at or below the hip level. Okay, so that's ideal. And if you want to go by figures, then it is around 0.49 of your height. So you don't have to start measuring your height and saying, okay, 0.49, okay, 56 centimeters. I did not mean that, okay? But what I meant was that you need to have it that it should be at or below your mid level. So if an assistant and a surgeon are not of the same height, how does that work? Well, it works by you adjusting the height based on your table height by probably using a stepping stool. So if you have a tall surgeon with an assistant who is not that tall, then you give them a stepping stool to lift themselves up on. If it's the other way around, then the surgeon steps on a stepping stool. Okay, so the stepping stool should be a wide stool, which actually is not a narrow stool like this where you can tip off. I mean, wide stool. And secondly, it should be a stool where you can be able to put your foot switches at the same time. So you don't have to have a wide stool and a narrow stool and your foot switch is down. So you have to do that every time you have to press diathermy. You get what I'm saying? That doesn't make sense as well. So it should be a wide and long stool, stepping stool that allows you to raise your height to the ideal height. Okay? Now we go on. Some angles. Very important that you want to maintain certain angles to ensure that you are working in a safe environment. The angle between the trunk and the arm should be at or below 15 degrees. So when you're operating, that is this angle. Okay? So this is not good. You've seen what I'm doing? This is not good. If you're going to be doing this, then there's something wrong. This angle is wide. So you should be in a position where your angle is always just narrow like this, 15 degrees. This is comfortable. I could operate this the whole day and not feel tired. You get what I'm saying? The moment I start doing that, the moment I start doing this, this means the table is too high, okay? Then there's a problem. So your angle between the trunk and the arm should be around 15 degrees. Same with the angle between the forearm and the hand, that's this way. So you can't be having your hand like this. Okay, that's opposite. It should be like this. This is how you've placed it. So if I go with this arm straight, okay, and then my hand, you see that angle? Around 15-20 degrees. So you're always operating that way. You're always operating supine. So try not to be doing this. You're right? You have to be safely pronated, not supinated. So you're like this all the time. That will help us with the ergonomic positioning. The ideal monitor height should be around 15 to 20 degrees gaze down. So you see, when I'm standing where I'm standing, and I'm looking at you people, I'm looking at you slightly down. Okay? So my angle, this comfort level is slightly gaze down. You've understood what I'm saying? Now, when you're operating, and if you're operating with a monitor here, so what will you have to do? This way. Okay? So imagine, you see what I'm trying to tell you? Angle up. When you have an angle up, the neck will strain, the neck muscles will strain a lot. So you're not supposed to have that. So the ideal situation should be that your height of the screen can be modified, which means that it is on boom arms that can go up and down. You've understood? What do we have in some of the places? We have those towers that are tracks, that are, the racks that are being moved, and majority of the places have that, right? And they have a screen that is fixed up there. Now, that's what I'm trying to tell you. It's not the ideal way of doing it. You don't want a tower with a fixed screen up there. And if you really have to fix it, it should be still mobile. But if you have to fix it, then fix it a little bit lower. Don't put it at the top of the tower where you can't, you have to look upwards. You understanding? So that is important. Otherwise, you're going to have a problem. Distance from the monitor. So how close or far do you keep the monitor? I give an example to you. When you go to a theater movie, how many of you gone to a movie in a theater? All of us? When you go to a movie in a theater and you're going to buy the tickets, I don't know whether you've noted or whether you've not noted, but if I ask you, which are the seats that actually disappear first? Whether you like it or not, you'll realize some seats disappear first, okay? So you're not the first one to go and book, but you're going in between and you'll realize, these seats always disappear, all right? Is it the first 2 rows? No, where that guy is sitting like this, okay? They don't. Is it the last 2 rows? Again, where you're sitting, yeah, those are expensive, balcony, all right? But have you realized that you're very far from that screen? Okay? So it means the screen is looking this way now, and you're busy seeing this one chewing, gum, and this person is looking at his screen, and that person is opening a soda bottle, which means you're seeing too many things apart from the movie. Have you understood what I'm trying to tell you? Your peripheral vision is outside the screen vision. Are you getting my point? And then you come GHI, FGHI levels, the row FGHI. FGHI, the screen is that way. So you're seeing the whole screen, you're seeing James Bond very close to you, all right? But you're not seeing this person opening a soda bottle and that. Are you getting my point? Your view is exactly what you want. FGHI goes first. So this is what I'm trying to tell you. So without knowing why, this is the reason. The reason is, if that screen, the diameter, our screen diameter is calculated, right? If they say a 32-inch screen, you know what that means. It's the diagonal diameter, okay? So from here to here is the diagonal diameter, which tells you the size of the screen. So if you take that distance and say 5x of that distance is actually the ideal spot for sitting and watching comfortably. You've understood? Same rule applies in theater. You don't want to go and operate on a screen that is here. Are you getting my point? It's too close. You don't want the screen that is sitting where that asthma is sitting, and I'm operating here. It doesn't work. So there is that distance that is comfortable to your eye, and that gives you a good view, that is not too wide and too narrow. Are we understanding? So that is roughly 5x. So if you have a 32-inch screen, that doesn't mean you start calculating times 5, and then you say, okay, let us measuring tape. All right? I didn't mean that, but you'll have a rough idea. So 32-inch times 5 is 160, 1.5, 1.6 meters. Yeah, put it there. You've understood? It actually gives you the best view. So this is an ergonomic principle that you need to understand. Okay? So it moves. You get the full view on the macula. You don't get partial view and outside, or you've understood? The next thing, the angles. We continue. What is the manipulation angle? The manipulation angle is the angle between two working instruments. So when I'm operating, this angle is my manipulation angle. Got it? Between my two working instruments. So I can have this angle this way, or I can have this angle this way, depending on where I put my ports. Now you understand what I'm saying? So when they're too close, you'll fight. When they're too far, you will not effectively work. I give you an example. Anything in our life, we don't think, but anything in our life. If I ask you, eat with a fork and knife, I want to know how many of you eat with a fork and knife like this. Do you do that? I want to know how many of you eat with a fork and knife like this. Do you do that? It's an automatic. You go at a certain angle where you're comfortable. Yes or no? No one taught you. That's how you go. When you cook, how many of you cook like this? You get what I'm trying? Look at it. Just think. Right? You're all going at a certain angle and moving. When you take a spoon at a certain angle and moving. Are you getting my point? So this is nature. And whatever is most comfortable is what we do. But if you're not careful about it, in this patient, when you're going to put in the ports, you may make a mistake of putting them too close to each other. So you did not want to do it, but your port placement was wrong. So now you're going to have this kind, they're too close. You know what's going to happen? You're going to fight it there. You've understood? Or you've just put them too far apart and now you're going at an angle and you can't, you've understood. So it's not naturally there that they are at 60 degrees. So you have to think when putting in the ports, how do I make my angle 60 to 90 degrees? You get what I'm trying to tell you? To make your work easy. Okay? So port placement, very important here. The second thing, other angles. Well, azimuth angle, it's okay, but again, it's good to know what it is. It's the angle between the instrument and the scope, okay? So the view. Manipulation angle, again, this one is what I was trying to tell you. It is the angle, as I've said, between the two instruments, and the azimuth is actually the center. So if you have a scope here, you have an instrument here and an instrument here, then you are at 30 degrees from the scope, but 60 degrees from each other. Make sense? 60 to 90 degrees from each other. Elevation angle. This is the angle I was trying to tell you about, the spoon or the cooking. It's the angle between the patient's flat and your instrument. Okay? So it's this angle. So this angle between this instrument and the patient's flat. So that elevation angle cannot be 90 degrees. You don't cook, you don't move your instruments at 90 degrees. It cannot be 30 degrees where you have that instrument there and now you're looking from it from here. It's too close. You're going to have a problem with moving your instrument and viewing. So you want this to be around 30 to 60 degrees. Okay, so we said eating with a spoon, cooking on the pan, etc. So this angle is too high, this angle is ideal. Makes the difference, you understand? So this is how it should be. We talked about fulcrum effect of hand instruments. We've discussed this, I'm going to repeat it. It's important to know in laparoscopy, your instruments will move around a fulcrum. So they will not move like this. Move this from here to here, so you do that. So you see, that is translational movement. Whereas, if I have to do laparoscopy, if I have to move this from here to here, I move my hand opposite. Only then it will move that side. So it's a fulcrum effect movement. You'll have to understand that. And therefore, another important point is if an instrument is around 36 centimeters, because that's the size of our standard instrument, this one, okay? If this is 36 centimeters, you want it to be placed, your port to be placed in such a place that you're roughly halfway in and halfway out. So what I mean is you don't want to put the uterus here, you don't want to go and put it there and now move here. Okay? You don't want the uterus there and to be put here, the port is here and now you're trying to move there. What happens? With this, when you're too far from the object of interest, a slight movement here means a huge movement there. You will have less precision. When you're this way, a long movement here will make a small movement inside. You'll have to move too much to create your movements. So again, lack of precision. The precision is best at a 1:1 movement. You move 2 centimeters, it moves 2 centimeters. Are you getting it? For that to happen, again comes the idea of I need to be sure where I'm putting my port. Okay? I need to know what kind of pathology I'm dealing with to help with that. Make sense? So this all comes down to how am I supposed to proceed by pitting my ports. So there is a guide we use, but the guide changes based on the size of the pathology, the site of the pathology. You understood? And sometimes we may need more than the ports we had initially thought. So when you're struggling, add an additional port to assist with that so that ergonomically you're protected. One additional port will not cost the patient a lot. It will heal, but it will help you not to be tired, not to be fatigued, not to injure yourself. Are we clear? So this was about the 2 closed ports when they start scissoring or dueling effect, the sword. So you don't want them to fight. Another thing, mirror movement. Ergonomically, it's impossible to move against the mirror. You will struggle. So what I mean by that is when you look at a mirror, even now, even today, when you look at your mirror, when you're changing, have you realized when you lift this with your left hand, your mirror person is lifting it with the right hand? Yes? So the mirror is an opposite image of you. Now, what I mean by mirror image or working against the camera is, listen, this is the pathology. This is my scope. This is my port and I'm working against, I'm working along the scope. Have you understood? I'm working along the view. This is my port. And now I have to work here. So I'm working this way. I'm being shown here and I'm working this way. That's working against the scope. When you work against the scope, you will move this way when you're supposed to move that way. You will start seeing opposite images. All right? So it's impossible to work, with experience, listen, I can grasp what I want, whether it's mirror or not, but that's not how you learn. So if you had to look towards the liver and you wanted to go that way, the scope should go that way, then I go this way. Not, this is here, I'm looking at it and now I'm doing this. This is opposite angles, you will struggle. Are we understanding? So don't work against the camera because you're seeing opposite images. So there comes down the ergonomics of the port placement that I was talking about. How do we arrange? You have to think based on the pathology. You have to think based on what you're going to do. You have to think based on the type of surgery you're going to do, depending on whether I may need stitching or not. You get what I'm saying? If I need stitching, then am I going to do stitching that is ipsilateral or contralateral in nature? So those are things that you will have to figure out. If you are not ergonomic in planning out your surgery, what will happen? One, you may get fatigued. So it means you're limiting how many surgeries you might be able to do. You get tired. When you get fatigued, what happens? You get stressed. When you get stressed, people around you get stressed because you start shouting. All right? Sometimes unnecessarily. You don't realize it, but then yes, it happens. It's nature. You're dealing with a life there, and anything that is stressing you is going to likely end up with a complication if you're not careful, right? So at that point, it happens. What happens with that? You may get, further if you don't correct it, you may get some injuries. I told you I have had injuries on my right shoulder that I still nurse 10 years down the line. All right? I have had an injury with my wrist. I still have a problem with it. Yes, I changed my techniques a little bit to be more ergonomic now. But yes, I've had these issues. You've understood? And it never gets back to normal. You'll always have some deficit. And because of not being ergonomic, eventually what will happen? You're likely to have a higher chance of poor surgical outcomes and complications. Why? You are tired, you mess up. Yes or no? It happens, everybody. You're never your full self when you are exhausted, when you are in pain, when you are stressed, when you are angry. You have a higher risk of complicating matters. Agreed? So why not understand that this is very, very important? Why can you get, or what kind of injuries can we get? We can get injuries because of the head being fixed on the monitor in wrong position for long periods. Shoulders, especially the right shoulder, the right shoulder, yes, more because of being fixed in a certain position across the patient. It's far from you. Leg, because you have one leg that is steady and then this leg is just doing that, you see? So there's a lot of pressure on this leg. You get it? So that is not good. This leg gets pressure. Injury because of the position not being right and your hands moving. So we said about the correct layout of the position. You can get injuries because of static work. So what do I mean? When you're holding a certain position for too long, and that comes down to our assistants. So when an assistant is told, hold this here and put traction. So that's all you're going to be doing for very long. Now, yes, you think that is okay because you're not using any much pressure, but you sit like this for 10 minutes, this hurts. You sit like this for 1 hour, this is injury. You've understood? So once in a while, it should be allowed to the assistant to release the pressure a bit, okay? And let it straighten up and then start again. You've understood? It's not good to maintain any position for too long. Those of you, and it happens even in other kinds of surgeries, those of you who may have assisted in vaginal surgeries, how many have assisted in any vaginal surgery? All right? A prolapse, colpoperineuropathy, a hemorrhoid. When you are now down there and you're told, retract, you know, you'll be like this for 2 hours. Like that surgeon is sitting on a chair and he's now going on and okay, hold properly. My friend, what will happen to your back when you finish that one surgery? Yes or no? Yes. You see? So, if we are not thinking, that's very unergonomic for this assistant. But it was ergonomic for the surgeon who was sitting on a chair and doing that. You've understood the difference? So, it's important that we think that, listen, this person is not in an ergonomic position. It's very uncomfortable. You get backaches immediately. Yes? So this is what we are talking about. Then force, depending on how much force you would put. I mean, I always tell my assistants, it's not about how strong a pull you have. It's not, I'm not trying to test somebody's strength here. But guys, you don't need extra force on anything. It's traction, but not over traction, okay? What are the kinds of injuries you can get? You can get injuries that we call cumulative trauma. You can get injuries that are due to repetitive strain, which means you're doing the same thing that is injuring you, that's hurting you, but you're repeatedly doing it, it will hurt you, okay? And musculoskeletal, okay? Who, according to these two, seems to be more ergonomic? This guy or this guy? This guy. So you see, that is not necessary. Don't bend when operating. You'll hear me tell, remember what I gave, all right, in time? Yes, don't bend. It's bad. You'll see us immediately say, do you want us to change position of the table a bit? Stand straight. Your hand moves. Don't do this. Don't bend, okay? It is not good for your health. So all these are different types of injuries that we can get: spondylosis, burning eyes, spondylitis and backache, chicken wing, scapula, this part. In the upper limbs, you can get the carpal tunnel syndrome, joint issues and hand finger joint, hand muscle issue, shoulder issue, leg pains, backache, etc. All right? So you have to understand that because of that, there are certain things that we need to therefore try and see how to go about to help us with these ergonomics. So we've done ergonomics of port placement, we've done ergonomics of positioning, okay? The other thing is about ergonomics of instruments. Now, there is also a problem here. What I mean by that is, let me give you an example. How many of us wear a size 7 glove? Nobody? Yeah. How many of you wear a size 7.5 glove? How many of you wear a size 6.5 glove? So you see what I'm trying to tell you? Why are you wearing different size gloves? Because that fits you. If I give you a wrong size glove, would you be comfortable? No. How many different size instruments have you seen? They're the same. So you see what I'm trying to explain to you in simple words? What makes you feel a size 7.5 or 8 hand and a size 6.5 hand will hold this instrument the same way? You understanding what I'm trying to tell you? So these are challenges we have, and there's nothing much we can do because it's difficult. But the ideal situation, and trust me, this might happen in the near future, this might happen. Yes, so what I was saying is, sooner or later it's likely to happen that we will have customized instruments. So the manufacturer will come and say, let me take your measurements, you know, and then say, okay, can I make you the instruments that suit you? Are you getting my point? Now, that might help us lots in the future. So then you have your instruments written, Dr. Joseph, so you know, these are my set of instruments, my size, you get my point. So I think that is an issue because between the designer and manufacturer, they don't ask us what we want, they don't test what we want, they don't check what size we want. So there is that issue about instruments and not being the right thing. There are some issues about laparoscopic instruments that are different from open instruments, and that's why we need to check this. One, they are long instruments pass through narrow ports in fixed positions. You have the fulcrum. You can't change much. Number two is the transmission force is around 3:1. So in an open instrument where you have the scissors, you open and it opens 1:1. You press, it presses 1:1 because the fulcrum is in the middle. In most of these. You get what I'm trying to tell you? Look at laparoscopic. I open 5 centimeters, it opens 1 centimeter. I'm just giving an example, all right? Yes, I'm used to this, but you see the difference? I press 5 times to get equal pressure here. You've understood? So my pressure required on a laparoscopic instrument is more than in an open instrument. Are we understanding? So that is something we need to get. The efficiency is also different because of the movement around this. The transmission force is different. The ratio is only 1:3. The movements are limited, and there are mainly 4 types of movements: the in and out, the rotation, the angulation of side and side, and up and down. So you have a limited movement In an open hand instrument, in an open hand or an open surgery, I can move the way I want with my hands. Can you see what I'm saying? So these are too many degrees of freedom of movement. The same thing now happens in robotic, but not in laparoscopy. You've limited your movements. Okay? So you have to be careful about that. And the thing we were talking about, I mean, why is there only one standard size? Why is there only one size fits all? It doesn't work. So we have to figure out about that. So how to solve these problems that we've discussed about? Because these things, I told you, are not good for us. Number one, exercise. Number two, nutrition, relaxation, maintain the ideal position and procedure. So make sure that is fixed. And to prevent it, you can warm up and do stretches before the activities that are repetitive, static, and prolonged. So what I mean is, take any profession, apart from surgeons who think they are super special, okay? Take any profession. Take a soccer player, all right? Take a swimmer. Take any of such people. Do you think these guys wake up in the morning and go to the football field ready to start playing? Don't they do warm-ups? Don't they do stretches? How many surgeons do that? When you're going to theater, you know, all right, how many? No, we think we are God. Now this is what I mean, wrong. That is our field. That is our arena. The way the football field is his arena. So before you enter the arena, why don't you warm up? Am I making sense, guys? I mean, this is common sense. This happens everywhere. But it doesn't happen with us because we are super special. All right? So this is wrong. Warm up, stretch up, then go in. Okay? Second thing, breaks and stretches from any sustained position every 20 to 30 minutes. So every half an hour or so, you've been doing surgery, get out, all right? Stretch. You're scrubbed, okay? Stretch. You don't have to touch anything unusual. Stretch. You've understood? Come back, start. Have you seen me do it? Yeah. So you see me sometimes move away from the theater table, stretch a bit, and then come back. Okay? It's because of this. It's not because I am tired. It's because I'm trying to avoid injuries. You've understood? Move away from that constant position for a while and come back. Respect painful positions and stop painful activity. Meaning, if you're doing something where it's giving you some pain, know there's something wrong there. When you're like this and it's hurting you, know there's something wrong. Position change. Position change. You've understood what I'm saying? Backache, position change. You've understood? So when you get pain, your body is warning you. Guys, there's something wrong here. Be careful. I'm getting hurt. I'm getting hurt. Don't keep on doing the same thing. Okay? Respect it and understand. And then recognize early signs of inflammation process and treat early, which means that if you do get eventually those backaches and all, and it's persisting after the surgery, no, there's something wrong here. This area is hurting. This area is hurting. Have it checked. Just go and see, okay, and tell them, can you please see my shoulder? I don't know, it's been hurting the last, 10 days or a week. So that you pick up the inflammation and sort it out before. Are you getting what I'm saying? Not waiting for it to injure too much and then you have to worry about it. So, maintain a neutral position. Keep your position of the back and neck relaxed with relaxed shoulders. Have the positioning the way we have said. So, I'll show you what is an ideal positioning now. So, let's do this. Let's stand up and let's do the positioning together. So what is ideal? Just a sample. Please stand up. So number one, let's stand with our hands by our sides where you have around a 15 degrees angle like this. So you're like that. Make sense? Not this way. this way. Number 2, the angle of the hand to this is inwards. It is slightly pronated. You've understood? So down, not up. Don't hold it this way. It's like this. Makes sense? The next thing is you are having the way we said, your table height at the right height. So you're operating at a height that is, so don't go that way. You're this way. You've understood? The best position to hold the instrument, if I told you don't hold it inside. This is in grip. It's over grip, okay, for long term. So you will position, close, and then stay this way, over grip, okay? The next thing is in a shoulder and relaxed position. We said view, don't look up, look down. Don't look sideways, look straight. You've understood? So you see, it is that position that I'm looking for. So this is an ideal position. Straight head in the axis of the trunk, without rotation or extension of the spine. 2, shoulders in a relaxed and neutral position. 3, arms by the side of the body. 4, elbows are bent slightly towards it. Forearms in a hands pronated position, and forearm we said is around 15 degrees inwards. Hands and fingers lightly gripping, not pressing and getting tired, okay? The table at the waistline, gaze down view 15 to 20 degrees, straight line principle, and triangulation. Make sense? So this is what we mean by an ideal relaxed position. Please sit down. So when you're operating, when you start learning laparoscopy, please keep these in mind. If you keep this in mind, you will survive. If you don't keep this in mind, you're going to have a very short career as a laparoscopic surgeon, okay? Obviously, we are talking of the team as well. So the pillars of a great surgeon, laparoscopic surgeon, would be he understands ergonomics very well. He does task analysis to break it down, break a task given to him into subtasks and do it. And he understands engineering or the equipment technology. Make sense? If you want to do well, it's important that you know these 3 aspects. So the engineering part, we are talking of knowing the camera, the insufflator, the electrosurgery unit, the monitor, the scopes, the insufflating devices, the recording devices, and he might or he should ideally know some video editing or movie making processes. In terms of task analysis, so if the task given to you is a hysterectomy, if the task given to you is suturing, laparoscopic suturing, I don't know, have any of you attended my lap suturing course? Anybody? No. Yeah, asthma. So when I am teaching lap suturing, I always make it a point to tell people that, listen, you people are learning the wrong way. Your focus on learning is wrong. And I mean it all the time, guys. Same thing with wherever you are doing it. Your focus is sometimes wrong. Let me explain that process to you. When I tell them suturing, so someone wants to go there, take the needle, and go and start doing the whole suture till the end. And then they fail miserably, get upset, and lose hope. Okay? If you want to learn well, you have to break that process down in your head and then do it. So what are the steps of suturing that you can break it down into? Number 1, how do I introduce this needle into this abdomen? Step number 1. And learn that as a process. So learn, I could insert it this way, I could insert it this way, or I could insert it this way. 3 or 4 options. So that when I give you, it doesn't matter. You'll insert it in one of the 3 ways. Safely. Second step, How do I load that needle onto my needle holder? Meaning, it's in there, you're using this. How do I load this needle onto this needle holder? That is the most difficult step, by the way, in laparoscopic surgery. So when I'm teaching suturing, that is a station on itself, where I'm only going to teach you loading. Okay? Loading and checking your needle, leave it down. Load again, check your needle, leave it down. Load again, check your needle, leave it down. So, don't think about stitching all the way through for now. Are you getting my point? Third thing, how do I, after loading, pass this this needle through this tissue in the correct way? So you've made an incision. How do I pass it so that I get the tissue tightly together? Not, it's a deep cut and I'm suturing here, this will leave a hematoma. So you see, how do I pass it through so that I don't have that complication? Make sense? So we teach you that. You have to enter 90 degrees, the rotation angle, the inclination angle should be this way, the depth should be this way. Learn that as a step on its own. The next step, how do I pull it out safely? So when you're pulling it out, you don't translationally pull it because you're going to tear the tissue, and when you're tying it, you're still going to bleed because you'll have made a hole here, and then made that hole into a laceration by pulling the needle through. What's the point of suturing there when your needle is just going to tear through the tissue? So how do you pull it out? You're pulling it out because your movements are only by wrist movement and they're only by rotational movement. There is no pulling. How do I finally make a knot that is secure? Now, have you understood what I meant by breaking down a task given to you to do the right thing? You now get my point? So when learning suturing laparoscopically, you learn it in steps. Same way, when you're talking hysterectomy, you guys come and say, yeah, I want to do a hysterectomy. And then you're thinking of how to do the whole hysterectomy. If you want to succeed, break that hysterectomy into sub-steps. You've understood? And actually, there have been studies that have been done where a hysterectomy was actually broken down into 91 executional sub-steps. And you start learning these steps one by one by one. And when you learn them one by one, you also learn the variations in that sub-step. So, variation in bladder deflection. All right? There is straightforward bladder. There is previous scar bladder. There is an endometric nodule bladder. There is a bladder where there is a fibroid over it. There is a bladder where... Are you getting my point? So, you're doing one step called bladder deflection, but what are you doing? You're learning the different variations that can come with it. Don't they come with variations in different shapes and sizes? Then, my friend, what makes you feel you learning the whole step at once is going to work? It won't work in every scenario. Same with every cesarean is not the same. All right? Guys, you learn wrong things. When you say, I'm just going to do a cesarean, it's not just going to do a cesarean. Every cesarean is different. A transverse lie will give you hell if you're not ready for it. All right? Then, so learn the ways. An angle that has started bleeding will give you bloody hell. You'll cry. You'll get a hematoma that will go into the broad ligament. All right? And you will keeping on going to make a nest of sutures at the angle. It will never work. How do you approach an angle that has started bleeding so that you don't lose it into a vessel that has slipped away into the broad ligament? Manano Kwisha, you'll reopen that patient. You get what I'm saying? So the question is, how do you do these sub-steps and its variations? Again, a point I always make here. The focus on learning here is wrong, guys. We are taught, not we, I don't teach it. All right? You are taught. The more you do, the better you get. To hell with that. You learn wrong tricks and you secure and make them your style of working. And you think if you have done 1,000 1,000 cesareans, you are now suddenly the best? No. You'll get that one cesarean where you will not do well. So the way is not to do numbers. The way is to learn it the right way. Then it doesn't matter. Bring anything in front of me. I will do it. Now, what I mean, my friends, when I trained, this is how I trained. In my whole post-graduation, I only did 21 cesareans myself as the primary surgeon. You would do that in a week. I'm talking of I doing that in 4 years. 21 as primary surgeon. I assisted over 5,000. Get the point. But every of these 5,000 was teaching me a different thing. At the end of the 21, I only did 6 hysterectomies on my own. 6. My logbook had 6 as primary surgeon. You've understood? Towards the last year, final year, I only did 6. But by the end of those, when I came out, guys, give me anything on the face of this earth. I kid you not. Anything. I would handle it without fear. Not because I did too many, but because I did them the right way now. You've understood what I'm saying? Every single case was taught to me that was possible on the face of this earth. Why? Because I was in a quaternary training center, not even tertiary. I trained in a quaternary training center, which means a center where medical colleges would refer to. We get referred to medical colleges. You're in a tertiary care center, right? Imagine if they cannot handle it and send it to a quaternary center. That was what I was trained in. But the training was this way. Are you understanding, guys? So focus should be different, guys. When I finished these 6 hysterectomies, but I came out, you give me anything on the face of this earth, I would do it. Yes, I have not injured a single a ureter in my life. Now it tells you. I've not reopened a single patient after a hysterectomy or a cesarean in my life. No, I've not. And I'm not kidding. These are my facts. All right? So I'm not trying to explain how good someone is. No, I'm not doing that. But guys, I'm saying the focus. Learn the right thing and you will be fine. You've understood? So guys, this is one of the best ways to learn. Break it down. You're given a task, break it down. What are the steps of this procedure? Why don't I learn this step, then move to the next step? And then again start what was different in this same step with the last case that is not in this case, and then move forward. Then every case, you will look at it that way. You've understood? So now, the day you come across a different variety of it, you will still handle it. You now understanding what I'm trying to explain? So guys, learn. If you learn this way, so you learn access, you learn exposure of adnexa, you learn pedicles of the upper pedicles, you're now learning the anterior leaf and the posterior leaf. It's not follow the step through. It's I'm learning only anterior step, anterior leaf, previous 3 scars, previous 4 scars, an endometriotic nodule, a bladder, You get it? A ventrofixed uterus that is fixed up to the wall. How do I approach it in different scenarios? You've understood? So you're learning one step in different ways. Got it? So from here onwards, guys, whenever you're taught or you're thinking about a procedure, try to break it down. When you're given a task, break it down, okay? And then do it. In future, this is likely is going to happen to improve our ergonomics. And I think some of these are already there. You might have Google Glass Vision. There is something called Apple Virtual Reality. You might get better motorized handles. So you just press it and it goes and grasps and you release and it says cuts and it will cut. You don't have to cut it yourself. And they've started, right? Robotics and motorized handles. Apple Virtual Reality, which means you may not need a screen anymore. You will have Google Virtual Reality here. And now you may be looking here or here or here, but you're seeing this. You get it? Because this camera view is transmitted to your glasses. So what difference does it make where you're looking? I could be looking that way and I'm still operating as though I'm seeing here. You've understood? And then I could be looking down the way I do in open surgery and I'm still operating. So I'm looking through this. There's an abdomen wall, but me, I'm seeing the uterus. Have you seen? So I don't need to worry about the screen anymore. It will happen, guys. It will happen. But that will now help us with our ergonomics. But till then, guys, you'll have to learn these things I'm saying, 15 degrees, 5 millimeter, 5 times. You'll have to learn it because you have to keep yourself safe. But over time, you guys will see it. I don't know about me in my lifetime. I'm not sure, but this will happen. And then things will be slightly different. So it's a change every single time. You get it? We've seen the whole range from when it started till now, and it's moving very fast. It's going to change as we move on as well, okay? Any questions, guys? So take home message, prepare well for each case, keep physically fit, tailor-make your surroundings and settings to suit you, and you only have one life with one body, guys. Use it well, all right? Don't take shortcuts. Thank you. Okay? Good. Any other questions in ergonomics? Questions in ergonomics? Questions so far? I told you, I mean, if you keep it interactive, you learn more. Lectures are the weakest source of learning. Discussions are better sources of learning. Okay? Presentations are an even better source of learning. Teaching is one of the best sources of learning, which means if I tell you to go and present tomorrow, you will go and research first to read. You'll look at different options, prepare your presentations, and then come. Won't you have done so much research on it? So when I tell you teach, you actually do much better. Why? Because you will read to come. When you come for a class, you just come prepared. You wake up in the morning, pack your bag, come and sit. Let's see what he says. You see, you've not read, you've not done anything because you're not responsible. So that's poor way of learning. Lectures are poor way of learning, guys. If you want to learn well, you have to learn this way as well. Start presenting, start preparing, read, come, discuss, have groups. You get it? So that's for your own learning as well, I'm saying. So sometimes, even when you have a group among yourself, don't come and say, let's just sit and discuss, or have someone present. And the next time it's the other person present. So that person will actually go and read that topic up properly. You get it? Come and present. So that way you consolidate your teaching. I mean, your learning even better. Clear? Good. So any questions, any discussions? No, you still like the lecture. Okay. Yes.
Actually, a question on the endoscopy. I wanted to find out if it's possible to sort of join any of the assignments.
Yeah. I mean, it's okay. You can link up with my team and see when it's feasible. I don't have an issue, but they obviously joined me for a reason. They are with me for a year for a reason. So most of the times it will be coming in as observer, because it's wrong of me to take that away from them. Okay, they have joined me for that reason. So you can come in if there are more cases and someday you get an opportunity. I don't mind. You can scrub in as well, but you still learn a lot even by just observing. All right. So yeah, feel free. Just talk to them. They know my list. Arrange and come. Okay. Anything else, guys? Yes, please.
You spoke about why the surgeon is supposed to stand on the left side. And if you, despite your dominant hand.
No, it's not like a rule. All right. I know so many surgeons, great surgeons, who stand on the left side. And I stand on the right side. I mean, I stand on the left side of the patient. I know so many who stand on the right side of the patient. So when we are doing open surgery, the right-handed surgeon stands on the right side. When you're doing laparoscopic surgery, the right-handed surgeon stands on the left side. And the reason is this hand now is, if I'm going in the pelvis, is now active. Okay? So I'm operating from up down. You've understood? When I'm standing on the right side of the patient, that is going to be difficult when I'm operating in the pelvis. So I can operate on either side, but my preference would be standing on the left side of the patient because I'm a right-handed surgeon. You've understood? And a left-handed surgeon will stand on the right of the patient. You get it? Yes. Anything else? Yes.
Mine is not academic. I just wanted to know, in your experience, in your practice, have you ever had a situation where you converted from laparoscopic to open surgery?
It can happen to anybody, but for me, touch wood, no. Again, in over 20 years. Now, that again does not make me an excellent surgeon, but it only makes me an excellent decision maker. So what I mean is, I still do open cases. So when I know that this one I may need open, I will go in open. You get it? When I know this one I will attempt laparoscopic, I have managed to open it, done it laparoscopic throughout. And that doesn't mean I only take simple cases laparoscopic. I take very complex cases. But if I've planned laparoscopic, I go laparoscopic. So in my head, I've planned it. You get my point? I've never said I've never opened a patient after laparoscopic starting. But those are patients I've told, I'll go in, have a look, but if I feel this thing is looking suspicious or it's malignant, or I will convert and continue laparoscopic open. Not because I got stuck. You get the difference. Not because I got stuck, because that now required me to probably open. You've understood? So that's what I mean by I have had to do it. But otherwise, if your decision making is correct, you have to. I do lots of pre-op planning. Those of you, they are with me. I do lots of pre-op examination and planning before I make up my mind on how I want to assess this or proceed with this. And yes, majority of the time it's laparoscopic. It doesn't matter how complex it is. But what I'm saying is, I've already made up my plan. I know what exactly I'm going to do. I did a very difficult lap myomectomy day before yesterday. Very difficult, okay? And but in my head, I had my planning. I had done my mapping of the fibroids. I go in ready to know where I'll put my incisions in my head before I go in. So that is what I mean by planning. A good surgeon knows when to operate, okay, or how to operate. A better surgeon knows when to operate, but the best surgeon knows when not to operate. Okay, so you should know that decision-making tree, that the most difficult decision is when not to do that. So because I'm a laparoscopic surgeon, I tell my patients, it doesn't mean every case is suddenly laparoscopic. I should be in a position to say, you might need an open surgery. Not because it's better, but because laparoscopy is better. For the patient, anytime, laparoscopy is better. I did that very difficult patient, I told you, day before yesterday. She goes home the next day. All right? Smiling, pain-free. Now, what more can I ask? Yes, I took maybe 4 hours struggling in there. But for the patient, that was better. Are you getting my point? So, you have to be able to decide that. Which one to go in for? Open, which one to go in for laparoscopic. Not it's because it's better. I did another one last week, which I thought was possibly malignant. It was a very difficult case. We did it with an oncosurgeon here as well. But at the end of it, when I went in, because we thought it was malignant, we went in open. Okay, and we went in midline because it's possibly malignant, right? To give us space. Then at the end of it, we realized it was not malignant. It didn't look, I'm waiting for the histology, but it didn't look malignant. So we realized, when I was intra-op already, I said, no, this one, I would have handled much better laparoscopic. And the reason was there was no space in that patient. She was a bit big and the pelvis was very deep. So I'm struggling open. So don't think open is better. Open is sometimes worse in those narrow spaces. Laparoscopy gives you great view and great access to those areas. You've understood? So laparoscopy has its major role in such cases. In difficult cases, it really changes the whole game. Endometriosis, for example, there is no bloody role for laparotomy. I'm telling you. You've known we've been doing lots of endo, and we've had these endo marathons and no to laparotomy. You mess that patient up for life because it just causes more adhesions. It's just a mess. When I'm dealing with here with previous 4, previous 5, previous 9, you wonder what was someone going in there the 9th time thinking? What were they thinking? You get it? It's not fair. On those patients, it's not fair. Imagine your sister, imagine your friend. Would you like it? Someone has gone in there 9 times and the patient is still complaining of the same symptoms. It's the wrong way of doing it. You get it? It just causes a forest in there that navigating through now becomes a challenge. Got it? So that, answers your question, that decision-making helps with prevention of such mishaps. Okay? Anything else? Good. I think it's almost 8. So I don't want to start a new topic now. We will probably have to leave it halfway. So next visit, Monday is a holiday now. So we'll discuss. We'll see when it's feasible. But next topic, we'll discuss the anatomy, the laparoscopic anatomy that you need to know. Again, a very important topic. I don't know how deep to go in the anatomy class, but I think you guys are postgraduates. You need to know the full anatomy of the pelvis. I don't think it's enough to know that's a uterus, that's a tube, that's the ovaries. Everybody knows that. So I think you need to know more depth than that, right? So I'll take you to the depth. If you feel it's deep end, let me know. But I'll have to take you deep end. It's important, right? You need to know that area. So we'll do anatomy next time. And then we will go into energy after that. Clear? Good. Thank you, guys.